it's wonderful actually to see how much was presented in ASH. And many of us were a little bit worried about ASH being presented virtually again. I thought that it was interesting because you can really focus on the presentations. You can really pause, go back, listen to it again. So I really actually enjoyed what happened in ASH. Clinically, I think from the precursor condition, there were a couple of very interesting presentations, one of them from the Spanish group from Bruno Pavia, looking at, instead of using 2220 as a one-time point for smoldering myeloma, why don't we look at serial time points in patients, look at their circulating tumor cells, look at their immune cells, and reassess patients as they progress? And I think that's the future for us in smoldering myeloma. It's trying to use not one-time point. You are not a one-time point when you're a patient with smoldering. We cannot just tell you you're high risk or not by just looking at 20% bone marrow plasma cells. We need more serial time points and using multiple other modalities, genomic, immune microenvironment, along with the clinical data to give you a better assessment of your risk of progression to myeloma. On the clinical side of therapy for smoldering myeloma, I thought Ola Lenger's presentation of KRD and depth of response matters in smoldering myeloma. And that was interesting because many of the studies right now, especially the ECOG study of lenalidomide, indicated that maybe response doesn't matter, that maybe the immune cell response is what matters to prevent progression. And the KRD data indicated potentially that MRD negative disease and depth of response in smoldering myeloma could potentially be important for us to achieve that long remission without end organ damage. And then overt myeloma, I thought the most interesting thing was transplant. It's back again here. It's, the Forte study, the IFM study, everything came back to say transplant still matters, which was very interesting for me to see that come back again to say we have still not eliminated transplant from the upfront setting. In the relapse setting, I think the dominating feature, of course, was bispecific antibodies, CAR T therapy. And here we go again, yet more bispecific antibodies. And I think that shows you that immunotherapy is here to stay, and it will be used not only in the relapse setting. I hope it comes as early as smoldering myeloma and not just in the upfront setting. I think novel targeted therapies, precision medicine like venetoclax, BRAF drugs, KRAS drugs was also coming into play here with very deep remissions in some of the patients. So that's starting to show us that precision medicine is going to happen in multiple myeloma finally, and not every patient will be treated the same way.